moving forward, what do we think are the driving factors in the next iteration or the next commitment to a New York-like program?
Well, the elephant in the room is Medicaid utilization. And, clearly I think supportive housing has value in terms of reining in Medicaid utilization for high-end users. I have a little bit of concern that shifting the focus away from chronic homelessness exclusively to Medicaid will alter the mission that got us here, which was to bring down the numbers of chronically homeless and homeless people living in the shelter system and streets. So I think we need to come to some way to put both of those agenda items into the next agreement, but bringing down both Medicaid utilization as well as continuing our effort to end chronic homelessness. I think some of the other driving variables are lawsuits. So there's, many of you know about the adult home lawsuit that the state lost, but then won on appeal, but is still an issue, so that we have to move. The state's going to have to move some people living with mental illnesses in adult homes into scattered site community apartments, and similar issues with mentally ill people in nursing homes. And then, as I said earlier, there's the whole issue about care coordination with health homes. And I think the next agreement also has to have some focus on moving people out of institutions, including acute care hospitals and correctional facilities, which New York 3 really did not have. I don't think the next agreement necessarily should be called New York, because I think that may be politically sensitive.
I would echo also what Frank said. And would just add that supportive housing came out of a grassroots movement, and at the time when it came to the fore, there was really, if you were a mentally ill individual, the only option you had, and you needed housing from the government, your only option was to move into licensed housing with other mentally ill people. And so that grassroots movement in partnership with government got us to where we are today. And but now the word that you hear mostly associated with supportive housing is chronic. It's either chronic homeless or it's people with chronic health conditions. And I had said at the outset that my concern is that we don't lose the spirit of what we had. Kristen Proud this morning from the Deputy Secretary referenced a couple times in her talk about families and young adults who have benefited. But I don't really hear, in terms of new housing coming in, any new money for those categories. The focus is on the Medicaid redesign team initiative, and that's not bad. My concern is that doesn't overshadow all else. In the story, the great story that was told this morning by the mayor of Ithaca, he described, living in a car and then living in a shelter and then living in different places. Well, that's not chronic homelessness, that's episodic homelessness. And so, and so we somehow need to, leave room for that group too, and not just become, let this overshadow it. And I think it's really incumbent upon us to be talking about, the importance of addressing chronic conditions and chronic health conditions and saving money. And the money part is obviously very important, but that's not how this was not just about saving money in terms of supportive housing. It was also about rebuilding lives, and not just people with chronic conditions.
The things that we're proud of that we did well is we kind of created a schedule and we stuck to it. We created a set of populations and very strict targeting criteria, and we stuck to it. I think what I would hope for in a new agreement would be to really do that same thing for outcomes. So really focus on what are we trying to accomplish? Are we trying to accomplish cost savings, retention, employment, what have you, and be sort of as clear and strict about that on the outcome side as we were on the population targeting side.
There are a lot of positives in having the 9 categories, a lot of expertise behind each of those categories, but it also allowed those categories to remain in silos. So how do we bring together both the expertise without losing or bring together the silos without losing the expertise. And I think that's something we have to keep in the forefront as well.
Frank mentioned it about housing more people, moving forward, housing more people exiting institutions, and we talked about chronic illness. I think Medicaid is definitely going to be in whatever comes next. Are there other populations that we haven't discussed that you think we should be for the next agreement, and/or expanding units for populations that may not have gotten as many units in this one?
The city engaged in an exercise, well, I guess about in early 2011, where we were contemplating what a next iteration of a supportive housing agreement would look like. And it included most of these 9 populations, but we added a few others. And mainly the ones we added were adults being discharged from acute care with complex medical or behavioral health conditions, who have a recent history of multiple hospitalizations and or ER visits, people coming out of correctional facilities, people coming out of nursing homes. It had more of a focus on the institutional sites. And we continue to want to serve youth with mental illnesses, as well as try to master the youth aging out of foster care dilemma. And the other populations we left in, but we tweaked the eligibility criteria.
Now, services are tied to people. You know, you get funded and there's $8,000 you get for this individual, and then you can serve them in perpetuity. And I think there'd be some merit in thinking about the services being more fluid, in being able to move those services. And so, for instance, it was mentioned at another workshop that one of the predictors of homelessness, you know, we have so many families in the system now, record high number of families in the shelter system, and that one of the predictors of families becoming homeless, one of the few predictors, is that if they've been homeless before. So one of the programs that CUCS has, and we do this in partnership with several other organizations, is what's called Home to Stay, is we work exclusively with families who have recidivated, and they're coming back to the system for the 3rd time, and then this time out, we provide them with, you know, so-called aftercare services, and are getting very good results. So one example would be that you would consider as part of supportive housing is that the job of the program is to work with a family who's coming out of the system, and you would then work with them for a set period of time. It might, you know, time limited. You could use an evidence-based practice, like, you know, and critical time intervention or something that would, and you'd work with them, say, for a 10-month period, and then you stabilize them, and there'd be a set goals that you would have, and then you would, you know, move on to another family. And it's just a different way of thinking about what supportive services or supportive housing would look like, because it is housing and it is services, but the services themselves are transitional, but the family goes into permanent housing.
I also think another supportive housing agreement might want to examine the role of rental subsidies without support services for homeless people to get them permanently housed, and also should examine the importance of rental subsidies for the supportive housing providers, because I think that's been somewhat underfunded in New York 3.